Good afternoon. Thank you for joining the We Can educational series. Today, Dr. Lynn will present on dental and oral manifestations of child maltreatment. We will be sharing the handouts for today's presentation in the chat in just a few minutes. We will also be sending a step-by-step guide on how to claim credit for the live webinar. To ask a question, you can use the question answer button on the control panel. Questions will be addressed at scheduled breaks. To obtain continuing education credits for today's session, you must complete an evaluation. The URL and a QR code to the evaluation will be displayed after today's lecture. After completing the evaluation, you will receive an attendance code for today's session, as well as a phone number. Text the attendance code to the phone number listed. After reporting your attendance, you should log into your account at ocpe.mcw.edu and click My Transcript to download your certificate. To view step-by-step instructions on claiming continuing education credits and to see a list of future webinar topics, please visit wichildabusenetwork.org/webinars. If you have any questions, please contact WeCan's coordinator, Elizabeth at cacs.wi.org. Now we will proceed with today's presentation.
Welcome, everyone, and good afternoon. This is Lynn Sheets, and I'm with Children's and the Medical College. I am the Sue and Bud Seelig Research Chair for Child Abuse Prevention there, with one of the largest, if not the largest, and most prominent child abuse programs in the nation. So I say that with a great deal of pride before we launch into today's lecture. I'm happy to be talking with you today about oral and dental manifestations of child maltreatment. The slide presentation, which is not advancing, so let me see what I can, there we go, is full of quite a few photos, and some of the photos, I don't know about you, but some of the dental and oral injuries I find particularly gruesome to look at. So if you need to avert your eyes, do so. I do have scheduled breaks in here, and I am more than happy to take questions as time allows. I have no disclosures to make and no conflicts of interest to resolve. The cases that you will see today have been de-identified through a variety of techniques, so that even if a case sounds familiar to you, there will be aspects of it that are not, and so no single case is an accurate representation of a single child. I do not provide legal advice, and so do not take anything I say today as legal advice. And then, as I mentioned, some of the slides can be disturbing, including this one, which I found interesting and particularly appropriate for an oral dental talk. And then a reminder to make sure you brush your dog's teeth, which I don't know, most people don't know, is it can extend their life just like it does in human beings. So the objectives today, I hope you'll learn some signs of dental neglect, although that's not the primary focus. Understand the importance, at least from a dentist or a medical provider, in considering mimics of what you think you're seeing. Describe the most common types of child abuse oral injuries, which are sentinel injuries, and explain the significance and urgency of sentinel injuries. So the scope of the problem is quite significant, as I think given the lack of dental care and access to appropriate dental care, we know it's significant in terms of neglect, in terms of facial injuries and targeting the child, the face as the child, and the mouth in particular of the child. That is very common. Facial and mouth injuries are extraordinarily common in child physical abuse in general. And in a study by NADU that is somewhat old at this point, but 59% of 300 abused children had facial injuries, and 11% of those children had intraoral injuries. These are relatively common. So you think about why the head, why the face, why the mouth. And if you give that more thought, the face, the mouth, the speech, the crying, what emanates from the face and the mouth really represent the who that child is, the person. It can be the source of annoying noises like refusals to do things, and also crying that maybe a caregiver finds irritating or persistent and intolerable. So the face and the head is often targeted. Most of these injuries are caused by blunt trauma. And one should always consider, if a child comes in with facial or mouth injuries, or whether or not those could have been caused during resuscitation or during some sort of medical treatment. We do the same like on thigh bruises in children who maybe are presenting with concerns of abuse. We need to think about, did they receive an immunization there? And so the same thing is true with oral, mouth injuries, and face injuries. We have to think about, was the child, was a breathing tube put in, or was a nasogastric tube put in? Was the child suction? And certainly in my career, I've seen suctioning, like aggressive suctioning and injuries from caregivers who became quite frustrated. So bruises and intraoral injuries in pre-cruising infants are included as types of sentinel injuries. If you'll remember, sentinel injuries are any bruise, mouth injury, or red spot on the white of the eye, which are bruises just on the surface of the eye, are considered sentinel injuries when they occur in infants who are not yet able to try to walk. We call that cruising, and 75% of children are able to cruise by 1 year of age. If a child's not yet able to cruise, any type of mouth injury or bruise or subconjunctival hemorrhage is concerning for abuse. And in bruising, we have to also think about a bleeding disorder. In any age child, an ear bruise needs to at least give serious consideration as to whether it was from abuse. They're unexpected in any age child. So oral, dental, physical abuse, if you just think about going from the outside in, that's what this slide is showing. You think about facial injuries and some of the other topics I've already mentioned. Then you have the lips, and you can get burns to the lips. You can get injury from a child who had a gag or a ligature put around their head, including their mouth. You can get blunt trauma to the lip, or busted lip, or even damage to deeper structures such as the teeth. And in children where there's a forcible insertion of an object like a finger or a spoon or a pacifier into the mouth of a child, you can get injuries to, well, we call them frenula, but it's that little bridge of tissue on the inside of your upper and lower lips that attach to your gum line. And then you also have one under your tongue. So each person has normally 3 frena or frenula. And in a pre-cruising child, any injury to those is completely unexpected. And then finally, if you go a little deeper, sometimes when people are frustrated or something is rammed into the mouth on purpose or accidentally, it can cause injury to the pharynx. Basically, when you open your mouth wide, you're looking at the nasopharynx on the back of your throat. And you can get injury there, or down deeper below what you can actually see. So we're going to start from the face and go inward according to that kind of overall plan. So we'll start with the face, and I won't spend a lot of time on this oral dental talk, but we do see facial injuries commonly, not just bruising, but we also can see burns. The face is the target of a lot of caregiver anger. If a child has been abused, they sometimes target the face. In this case, you see on the left, the cited paper that demonstrated what you expect to see when a child is forcibly placed down into a hot liquid. We call that a scald injury. It's a burn from a hot liquid. And when that is done, and water can be one of those hot liquids, but we've seen these with hot oil as well, you get this kind of a distribution. You can see sparing sometimes around the mouth and around the nose because of an air bubble there, and also some creasing because the child is crying during the event. This is an 18-month-old with scald burns to the mouth and also had them to the genitals. Again, the face of a child can be the target. The fact that the genitals were involved may have been some talking back around potty training. It may have been some challenging behavior. As we know, 2-year-olds can engage in challenging behaviors around toileting and eating. And so I don't recall what this child, the trigger event was. The burns are quite severe, and any burn to the face or to the hands or to the genitals should be taken very seriously and usually seen by a burn surgeon, as they require even milder burns, sometimes some special care. Here you have the same child, and you can see some of the burns extend into the mouth from a hot liquid and onto the tongue. When you see injury in the mouth, instead of it having a scab or looking like what you're familiar with, you usually get a different kind of appearance to the ulcer. It often has this yellowish or whitish appearance, especially as it heals or gets coated with essentially a mucosal scab or granulation tissue, and they can appear white or yellow. Interestingly, as most of us know, you've had a bite, you've bit yourself on the inside of the mouth. The mouth and any other mucous membranes, including those of the genitals, heal very quickly and usually completely, which is a wonderful thing because they usually do not require a lot of intervention. So here you can see that granulation tissue. Again, this is essentially a mucous membrane scab, if you will. This was another facial burn. You might be able to tell, even without the label, what could have caused it. This was a curling iron that got caught, and you can see grazing is what we call this. This is where the child is moving, the object is moving, or both. And you can get some lighter burn with deeper burn, but many of them have the shape of the curling iron. And so it got tangled up and against his face. This was an unintentional burn, as I recall. And then we see gag injuries. These slides were from Dr. Barbara Knox, who was in the state of Wisconsin for a while. And this child had true ligature, that it went all the way around the child's neck and wrapped into the mouth. And we call it a gag injury because the mouth was involved. So most oral and dental injuries from abuse are from blunt trauma. As I indicated, they can be from a slap, a punch, ramming injuries of something being very forcefully inserted. And then you can get sometimes collateral kind of injuries if the child is shaken or slammed. You can get even distant injuries depending on what the child's body is subjected to or the head is subjected to. So if a child's hit forcefully in the head and the head is able to move through an arc, kind of essentially almost like you think of a whiplash type injury, you can actually get intracranial injury to the brain and bleeding on the surface of the brain. So it's pretty common in especially young children who have severe blunt trauma to perhaps the mouth or to the face, that sometimes the emergency department may want to do a head CT and just make sure the brain and skull and all of the contents are okay. So this is a blunt trauma to the lip. This is just what a bruise looks like on the lip, and it actually often extends on the inside of the lip. And here you can see that on a different child. We call these petechial bruises, and you can see these tiny little red spots. Those are from burst capillaries. They're some of the smallest blood vessels in this case, the mucosa, but they're also in the skin. And when they burst, you get tiny little bruises. And when they're bunched together like this, we would call that a petechial bruising. And there it's actually coming down onto the upper labial frenulum. Here you can see a little bit larger petechii. This could occur from either blunt trauma to the mouth or from a petechial or an asphyxial event, such as maybe somebody holding something over the child's mouth and nose, perhaps in response to crying. This child also had slap injury to the cheek, had a subconjunctival hemorrhage, the little red spots in the white of the eyes, and had these periocular petechiae and intraoral petechiae. And this was from a parent who became very frustrated with the infant crying. This was a different case where there was a tiny little bruise on the inside of the lip, and occurred when the child was shaken, then thrown into a crib and hit the bottle laying on the bed and caused a tiny little injury inside the mouth. So big or small bruises in pre-cruising children are sentinel injuries, and they are very suspicious and highly correlated with abuse. And then medically, it's urgent that they be considered not only for abuse, but also a bleeding disorder. This is a child with a laceration, which is from blunt trauma to the gum. You can see the child does not have teeth, very young infant. And this infant had other injuries from abuse and had this laceration or tearing, if you will, of the gum. Usually without even stitches, these kinds of injuries will heal completely, and sometimes even without any scarring. Here you can see the blunt trauma to a child's mouth, where this child's mouth was hit, and you see a patterned bruise. I hope all of you can see that here, where the canine, the lower canine, caused the pressure, the trauma against the lower canine, and then the pressure against the upper canine, this tooth, caused this. And it's essentially an outline of the implement, if you will, because in this case, somebody hitting the child in the mouth pressed the lips against the underlying very hard surfaces of teeth. And you see capillary tearing or this petechial bruising that outlines the tooth. So it's kind of a high velocity impact injury on the inside of the mouth. I'm going to pause and look and just make sure we don't have any questions. I do not see any. Thank you to Elizabeth for handling logistical questions. So this is more than you probably wanted to know about a tooth and anatomy. And this is something that, frankly, when I need to know this, I look it up. I think I would recommend the same for you, but some basics of tooth anatomy are probably familiar to you. You know, the teeth sit in the in bone, and each tooth has its own blood supply. We call this whole neurovascular bundle here. This is the very living part of the tooth, and so is the bottom part of the tooth that's down in the bone. We call that the pulp, and both arterial side and venous drainage side go in, as do nerves. And all of you know from experience probably that the teeth can be quite sensitive and have nerves within them. The other thing I want you to notice on this diagram is that the periodontal ligament or membrane is an important connective tissue structure that also has vasculature and nerves in it that holds the tooth quite firmly in place, unless, of course, it's going to be shed. So it's important. I really wanted you to have this concept of the periodontal ligament because it becomes important on the dental injuries. So dental trauma is where we're going at this point. And we're from least severe is that the tooth isn't hurt, but from least severe to most severe is the way these are ordered. And these are easy to look up online. Treatment for these are easy to look up online. So if you are dealing with a child who has a dental injury, calling your dentist or your pediatrician or primary care provider are good things to do, but you can also look online and get some emergency advice for what to do. So the mildest form of a dental trauma is called a tooth concussion, which may sound strange because most of us think of concussions as a brain injury. It's actually a functional brain injury where there is the neurons in the brain are not functioning normally, but if you do a head CT or an MRI, they usually look normal. But here we have a tooth concussion, and that's where the periodontal ligament is injured. And as you might imagine from that previous slide, if a tooth is struck and you have this injury, the ligament that's holding it in place, or that membrane that's holding it in place, would probably be the first to suffer injury. And it's painful. That's a neurovascular bundle running along the ligament or along the membrane. But in these cases, you have pain, but the tooth is not mobile, so it doesn't wiggle. And the tooth is in its normal position, and the tooth will heal well. No specific treatment is needed other than you need to prevent re-injury while the tooth is healing. The next most serious is a tooth subluxation. Subluxation simply means a misalignment, if you will, where it's moved to the point where it's trying to dislocate, but it hasn't dislocated. And so the subluxation, what you see there is again, injury to the periodontal ligament. In this case, the ligament is damaged enough that you get some mobility of the tooth. In other words, it wiggles, that hurts, the child complains or cries. And then you often have bleeding around the gum line because that's where you can see where the periodontal ligament, bleeding from it is most visible. And if you tap even on the jaw or on the maxilla, the upper part of the jaw, you get tenderness to percussion. You certainly get tenderness to percussion. If you tap on the tooth, it's quite painful. It's very sensitive, but the tooth is not displaced. Then you can get complete luxation where the tooth is dislocated and it's out basically. And that's a pretty serious injury that pulp may still be present and it may still be alive. And so especially if the displacement where the tooth is not in its normal position, if the tooth can be put back in and fixed in that location, you may have complete healing and complete vitality of the tooth. But in many of these cases, that does not happen. And then finally, the worst is a tooth intrusion where the tooth is actually shoved down into the socket and the tooth may not even be visible. It's actually deep in the gum and it may appear to be missing, but it's there, but you can't see it. So abusive dental injuries span everything we just went through, and some that are even more chilling. They can vary from anything from a concussion to complete to luxation to the intrusion. And this is often from blunt impact to the child's mouth. If a force, particularly a hard object, strikes only the tooth, you sometimes can get just chipping of the tooth, but you can get these more serious injuries, including damage to the bone itself that's holding the socket or the pulp in the tooth. There are case reports in the literature of forced dental extraction, basically where a caregiver, loosely used, pulls a tooth without them being even loose. And as you can imagine, that's would be extraordinarily painful and disfiguring. So what to do, as I mentioned, you want to make sure there's a reference here you can look at, but you can also look online as far as what to do. Dental trauma, many people think, oh, if it's a baby tooth, is not serious, but that's really not true. Any trauma can cause a loss of vitality to the tooth. And it may look okay for a while, but weeks later it becomes discolored. And there you have lack of vitality to that tooth. It's no longer fully alive. And even dental trauma to baby teeth can have lifelong consequences. It can lead to root resorption, where and you can lose loss of that bone that surrounds the socket. You can alter future tooth eruption, even to the point that it's permanently disfiguring, and may need cosmetic therapies treatment. So here, as I explained to you, a subluxation is just the damage, but no displacement of the tooth, but the damage to the periodontal ligament. And there it looks like the tooth is in its normal place, but you can see this blood coming up from around where the periodontal ligament has been injured. This is a lateral luxation where the tooth has been moved, but it's somewhat subtle because sometimes people's teeth are crooked. And so here you have a sign that you have a subluxation, but you also at least have a concern that the tooth was moved. And indeed, when you look from the lateral aspect, it was moved. It's actually sitting out of place. Here's the normal socket, and it should be back in here. And you have a partial fracture here of the socket itself. And if you just look at this, you might think it's just the subluxation. And you'll want to make sure when you're dealing with dental trauma that you get usually a dentist involved. Most dentists are very familiar with dental trauma. And then, as I mentioned, sometimes with loss of vitality of a baby tooth or even an adult tooth, you get this change in color that indicates that that tooth is at least partly not vital. A dental fracture where you have, if it were just a small part off the top of the tooth, maybe here, you could call that a chip, but here you have a deeper, what's called a fracture. You see this is deeper fracture, and that's a more serious and has cosmetic implications as well as functional implications. So you'll, if you look at the resource that I noted, you can see kind of what to do if any of these dental emergencies happen, and that's not the focus today. So again, I'm looking over to see if we have any questions, and I don't see any, and so we'll continue. Frenulum injuries. So remember we're going, we started with the face, I then talked about lip injuries and then dental injuries. And I've put frenulum injuries as a deeper injury, but two of the frena or frenula are actually before you get to the teeth. They're the ones associated with your lips, but then there's one under your tongue. And in general, if you think about injury to that little bridge of tissue, the injury itself is medically trivial. It does not require treatment. It will heal on its own. However, if it's a pre-cruising infant, it's a very, very important injury, significant, deserves immediate medical attention, and the infant needs to be evaluated in this case, if it's a frenulum injury, for child physical abuse. And most of you probably know from previous sessions that in young children under the age of 2, we would routinely look for hidden or occult skeletal injury, also intra-abdominal injury, also chemical injury. We screen for drugs through a urine drug investigation. And in the youngest, we also look for intracranial injuries through using a head CT under the age of 6 months. So frenulum injuries in older children happen not uncommonly. In fact, I probably should say commonly. Children who are walking and fall against a coffee table or have a stick in their mouth and run and it gets rammed against a labial or lingual frenulum. You can see these pretty commonly as accidental or unintentional injury, and usually deserve some medical attention just to make sure you don't have dental trauma or other more serious injuries. Some examples of this is just to orient you, this is the upper lip, lower lip, and you see the gloved fingers of the examiner here. And what you can see is this is a young infant, no teeth, and you can see right here where the upper lip attaches to the gum line, you see where the frenulum or frenum, either is correct, attaches, and there's an injury there. And remember what I told you about the white appearance of a healing of an injury. It's essentially a scab or granulation tissue. This is a child who suffered abusive head trauma and had the injury underneath the tongue of the lingual frenulum. And when you see these associated with a lot of bruising, one needs to think about, is the mandible, the lower jaw fractured? Because you can have a fracture of your lower jaw and the bleeding associated with that fracture can show up here underneath the tongue. And so if there's a lot of bruising here, they usually need a facial CT and a pretty thorough evaluation for a possible mandible fracture. This is a healed frenum injury, upper lip. Frenulum is injured, but pretty much not completely healed. This was an abusive head trauma case, and this child had had a previous sentinel injury that now is almost completely healed at the time that the head trauma happened. So if a caregiver had noticed bleeding from the mouth in this pre-cruising infant and brought the child for attention to a knowledgeable medical provider, the abusive head trauma may have been prevented. So this in and of itself does not need specific treatment. Tongue injuries are a little rare, but they do happen. They can happen from unintentional or accidental injury as well as intentional injury. And this is a particularly gruesome one. Of the child's tongue was actually severed here about halfway across. And this was a very young child who fell from the bed and had this injury. Abuse was suspected, but the rest of the workup was negative. And remember, the workup in these young pre-cruising infants is just further injury surveillance. It's not done to rule in or rule out physical abuse. And so in this infant, we were left with this isolated injury, a suspicion for abuse. It did get reported, but with really some unanswered questions. Here we have a deeper injury. This is actually injury to the palate. So to orient you, here's the tongue, here's the lower lip, the upper lip is out of the picture here. This is the right side of the child's palate, inside essentially the roof of the mouth. And you can see some abrasion here, bleeding, bruising, and also then an open wound here with that granulation tissue. And that can be from something being rammed. It could be theoretically from a burn, but to not have burned anything else would be unusual. So, and then going even deeper, you can get blunt trauma that goes deeper back into the back of the throat. These are very, very serious injuries in young infants. And the infant may demonstrate some feeding difficulty after this is caused. They're fussy, these hurt, but they may not have specific findings that you can see when you look in the mouth. And usually in these cases, we ask our ear, nose, and throat doctors to take a look, because the injury may be beyond what you can see, particularly if it was caused by a finger or a spoon or anything that can reach back. And these injuries are at risk of actually going down and extending down into the middle of the chest, the mediastinum. These injuries can be life-threatening, and so deserve quite a lot of attention and diagnostic workup to make sure that the child is going to be okay. These are typically the retropharyngeal abscess, which is an infection, you can get injury under 6 months of age, but under 6 months of age, these don't usually become an abscess. The abscess can happen after 6 months of age when the child has a more developed immune system, including that lumpy, bumpy appearance of the back of your throat, which is lymphatic tissue, sort of like little lymph nodes. And then, of course, you can get burns to the back of the throat. So just like any other type of maltreatment, one can co-occur with others. This was a 2-year-old child who was actually in foster care. She was in a pre-adopted foster placement and had 2 reports that were anonymous of maltreatment. She was being followed closely by some subspecialists for feeding problems, and had a nasogastric tube, as you can see right here, associated with much more trauma than you'd expect. And in fact, if you look at this child's nose, you'll notice it looks abnormal and asymmetric. You can see the normal ala here, which is the wing of the nostril. But this one, it looks depressed, it looks pushed down, and this child had chronic injury to the nasal septum, the middle of the nose, and a resorption, permanent injury to the nasal septum that was causing kind of the flattening of the nose in this child. She had other injuries that were highly suspicious for physical abuse as well. And when she had a skeletal survey performed, as well as a facial CT and head CT, she actually had a total of 9 fractures. She had dental trauma. She had 2 fractures of the mandible. The mandible is your lower jaw. And like any curved bone, when you see a fracture in one place of a curved bone, you have to be suspicious there may be another. Curved bones often, not always, but they'll break in 2 places when you have a break because it curves. And this child had the obvious nasal trauma. And her feeding difficulties were well explained by a lot of adversity. She was being abused every time her NG tube, nasogastric tube, came out. She was being held down. It was forcefully being inserted, causing ongoing trauma and emotional trauma to the child. She also had a fracture here in her mandible. You can perhaps even see some bruising associated with that and dental trauma associated with that. And even once the physical problems that this child had were treated, she had a feeding aversion. She had so many bad, like traumatic experiences associated with eating that it took a long time before she was able to be fed in a way that was somewhat normal. Keep in mind also the mouth and the face can be physically abused, but the mouth can be targeted in sexual abuse, which usually leaves absolutely no injury at all. And we have a mistaken belief in our society that sexual abuse happens in verbal children, but doesn't happen in babies. And as a former reviewer of child sexual abuse images, what used to be called child pornography, but child sexual abuse images for dating or aging of the children involved, I can tell you that infants are abused. The goal is usually not to hurt the infant, but for the pleasure of the perpetrator. And when they are orally abused, it may cause them to cry, but usually no injury results. Sometimes, however, children are forced to do things, and you can see injury in the mouth. You can see sometimes gagging injury if they're tied up, if you will, and other injuries, distant injuries from the assault. You can also see sexually transmitted diseases in the mouth. So here you're, just to orient you, that you're looking at the hard palate of a child. This is an older child with teeth. This isn't an infant, but you can see these are from suction and possibly blunt trauma. And occasionally we see something somewhat similar to this on the palate. You can see sometimes petechial bruises from those kids who use suction to handle their postnasal drip and create so much suction that they can even sometimes cause petechial bruising. That's relatively uncommon, but it does occur. And this is a particularly rare setting where it's from sexual abuse, and this is from the American Academy of Pediatrics slide set. So just like you can get venereal warts in the genitals and anal area, you can get them in the mouth. This is not a mouth. When you first look at it, you might be trying to orient yourself and thinking maybe these are some teeth. This is not. This is looking down into the air tube. And so these are the vocal cords on either side that normally come together and allow us to phonate or push air through and make various sounds. But in this case, you see this sitting there, and this is a papilloma, and it's caused by HPV, which is the virus that can cause venereal warts, but it's also highly associated with a lot of genital cancers in later life. And I would just encourage you to encourage families and in your own family to have children immunized against HPV as young as age 9 is when it can be performed. And so I would encourage all of you to encourage others. If one becomes exposed to HPV, then HPV kind of stays in people's bodies, much like chickenpox does or herpes does, and can lifelong present a threat, particularly with certain types of HPV, for cancers, including laryngeal cancer. This is a patient, obviously not a young child, who has HIV, so has an immunodeficiency. And you can see not only HPV lesions, this lumpy, bumpy character to the inside of the gums and maybe even onto the palate a little bit, but also quite frequently they have infections around the teeth, a gingivitis, and this patient certainly does. So this was a severely sexually abused, assaulted. This was by the perpetrator, who was eventually identified, an acquaintance to the child, but she had these oral lesions and really severe genital anal trauma. And so we don't know if she was hit in the mouth or whether there was also sexual abuse involving her mouth. But anytime you have mouth injuries, you should be thinking not only is this an assault or physical abuse, but could this be sexual? We do see medical child abuse, which is the preferred term to the older term, Munchausen syndrome by proxy. We know that that can involve the mouth and can involve caregivers who seek attention by suffocating, covering the mouths, asphyxiating young children, and then stop right before the child gets into very serious medical difficulties. They often will call 911. They begin resuscitation after they've done it. And then they are deemed heroes. They save the child from this event that remains unexplained because, of course, they don't say what they did to cause the event. So these are kind of your classic, some of the original reports by Hall and Sir Roy Meadows were of these asphyxial events involving very young infants and children. Dental neglect, I would like to encourage all of you to think about this a little bit differently. It is rare to see a parent willfully withhold dental care for their children. More commonly is a lack of access to dental care. And the state of Wisconsin has been particularly stubborn about authorizing hygienists to do some of the basic dental care. And I think that's gradually moving, but we don't have enough dentists in the state who accept Medicaid. And so this becomes, in most cases, an access issue. And so if you're going to call it neglect, I think you have to start curious. You need to provide resources. You need to provide access. And most caregivers, most guardians and parents will readily accept dental care for their children. I think in general, unless needed, we don't necessarily need to call it neglect. We can call it that, but then state that it's an access issue rather than a maltreatment issue. So oral dental neglect can have long-term consequences. Oral health is really tied into your overall health. Most of us know that now. That's become more general, common knowledge. And chronic gingivitis, or that chronic inflammation from not having good oral hygiene, causes this state of chronic inflammation in your body that is quite toxic and can lead to heart disease. It can lead to worsening of diabetes. It can lead to a lot of conditions that are caused by a chronic state of inflammation. So oral health is critically important, not only to your emotional, your social, your financial well-being, your overall sense of energy and your total quality of life, but it's also linked to early mortality and morbidity from other diseases. So these are just showing the various stages, and it's like from top to bottom is from mildest to most severe. Some of you, if you saw this child, one of the things I want to point out to you first is notice this area of marked redness around the outline of the tooth. That's not normal. That's inflammation. That's chronic inflammation. That's important to notice. And you'll notice right up against there, you see these whitish areas. That's not a normal place to get plaque or that buildup of the mineral deposits. This is actually early decay that can look that way. And so it goes along with the chronic gingivitis. And if you get good dental care and oral hygiene in, this is all reversible. We don't want it to get to this point, but it's reversible. But then you get to some of these brown lesions that seem to cause these seascapes or these patterns out onto the tooth, a variety of patterns. This is very severe. It's intermediate, kind of these areas of decay in the enamel. And then later stage lesions, the teeth almost become pegs. They look very abnormal. They're not there. This child's gotten treatment. And the way you know that is the gum is not particularly inflamed at this point, but long-term damage has occurred, as you can see. And then really another case of very severe later stage nurse bottle caries. It's interesting, this doesn't indicate just poor oral hygiene, but there is also a genetic component to this and also an infectious component. Mothers give their mouth bacteria to their children, and there are certain types of strep, I think it's a strep I'm recalling on my memory here, that can lead to a predisposition to dental decay. So if you're a child with that and you are going to bed with a bottle and have a bottle, or you have milk or other sugary substances bathing your teeth, and you have this particular type of bacteria, you're going to progress quicker to nursing bottle caries than, say, a child who doesn't have that bacteria. So some of this is out of the control, or at least the predisposition is out of the control of the parent. So all children need good oral health, even before the teeth erupt. Wiping the gum lines of young children before they go to bed, it sets them up for a routine and sets them up for better oral and dental health. I've talked about that. These are cases of more severe, and please take it with air quotes, dental neglect. It's likely that there was an access issue for this child to get into a dentist. And by the time the child is having problems chewing, I can assure you, by the time this has become this way, this child's having problems eating, sleeping because he's hurt. This child's being teased at school. There are all sorts of secondary harm that result, and this child needs a lot of treatment to heal. So some of you, you probably haven't seen this. These are children who bit down on electrical cords. Just thinking of another type of neglect that can affect the mouth. And you get these electrical burns that are typically at the sides of the mouth. And these are particularly disfiguring, and they're hard to treat. And often the child is left with permanent scarring. And then you can get other types of neglect. This child got into a household, or it was actually an industrial strength cleaner that was being stored in a drink bottle. And the mother had removed it from her place of work. It was in one of those like convenience stores drink bottles on the floor where this 13-month-old was able to access it. She did. She had chemical burns here on her chest, neck, face, and also in her mouth. There are lots of mimics, and I just bring this up in the interest of being complete. I'm not going to go through all of these, but I'll just show you a couple of them. Some of the ones you should know about are not every bruise in a pre-cruising infant is a sentinel injury, or if it's a sentinel injury, you need to think about the bruises that we expect. And more, and I think this is about to be published, I'm told, is that you can see these tip of the tongue bruising from high suction bottles and nipples. You can see what are called suction bruises on the forearms of babies, and this is a classic shape where the baby sucks on their own forearm so hard that they get like this, that they get a bruise. And I thank Dr. Rabbit for these pictures. And then sometimes a baby will suck hard enough that you can even get blisters and get sucking blisters. So I think I'm going to stop there. The rest are a variety of other, there's one other I want to show you, and it's this. This is a common mimic to bruises and burns in California, where kids may be sucking on limes or sometimes lemons, and it photosensitizes the skin. And you can get these perioral lesions that look like that or look like this on the body. The key points, and we have, it looks like at least looks like 3 or 4 minutes for questions if people have them. Your handout has some references. I did include a more up-to-date reference that's fairly recent from the American Academy of Pediatrics. So I'll pause here. Please make sure if you have a question that you put it into the question pane, not the chat.
All right. Thank you, Dr. Sheets, for your time today and for giving such a wonderful presentation. I'll ask you to leave the attendance slide on the screen for a couple of minutes. Participants, please navigate to the SurveyMonkey evaluation to complete an evaluation and receive a code for reporting today's attendance. You can access the evaluation at surveymonkey.com/r/WICAN June 23, all caps. The code will work for this session only. You can also use your smartphone's camera feature to scan the QR code on the screen and complete your evaluation. Then log into your account at ocpe.mcw.edu to print your certificate. Please join us for next month's webinar with Lynn Cook and Sarah Haberlin. They will be presenting on pediatric strangulation updates and statewide efforts. Thank you for being with us today.